Thank you, Memphis Breast Cancer Consortium, for this opportunity. I am privileged to work at the West Cancer Center and Research Institute and be a part of this initiative. My name is Sonia, Benn, and I'm a medical oncologist, a breast medical oncologist. Let's talk a little bit about treatment options for breast cancer. So I like to break it up into pretty much two segments, even though we understand that they all work together. So we want to talk about local control of the breast cancer and then what we call systemic control, decreasing the risk of the cancer coming back anywhere else in the body. So once the diagnosis is made, then the one curative approach is to have the cancer removed, and that is done through surgery. The surgery options would be what we consider a lumpectomy, or where the surgeon simply removes the lump. Understand that the surgeon will always check the lymph nodes. This is done by a sentinel lymph node biopsy, where they inject a dye at the site of the cancer that goes to the closest lymph nodes. Then we're able to remove just those closest lymph nodes. Of course, sometimes if a cancer is diagnosed later, there may be a number of lymph nodes involved, and the surgeon will have to do what we call an axillary lymph node dissection. The axilla is the armpit, and they remove a number of lymph nodes under the armpit. We want all the cancer removed. But what if a lumpectomy can't be done? What if that tumor is too large? Then they may consider a mastectomy. That's where the entire breast is removed. But understand, especially now that we're so much more sophisticated, even if a mastectomy is required, in several cases, reconstruction can be done. And so hence forms your breast cancer treatment team, the surgeon, the plastic surgeon, to attain a better cosmesis, a better outcome of the breast. Also, under local control, once that cancer is removed, we want to decrease the risk of the cancer coming back to that breast. So we offer radiation. Radiation can be given in several ways. One, it can come externally and towards the breast. That's called external beam radiation, the most common type. Now, there are some places that are really sophisticated, and they have intraoperative radiation, where a device is placed actually within the operating room. And then there is APBI. We call that accelerated partial breast irradiation, where you can do a shorter course of radiation. Again, a catheter is placed, but this time it's done after surgery. All of these radiation techniques, however, work towards local control. They only work the areas where they hit. They decrease the risk of the cancer coming back to the breast. Well, how do we decrease the risk of the cancer coming back anywhere else in the body? That's also important. And that's where we want to achieve systemic control. That's where we would use, for women whose cancers are estrogen and progesterone receptor positive, we would utilize a pill. For women who may have more advanced cancers or triple negative cancers, no estrogen, no progesterone, no protein called HER2, those women require chemotherapy. The beauty of this here is that even though those cancers are very aggressive, they also respond very well. So in those cases, we may actually use chemotherapy up front. That will shrink the cancer, ideally take it away, and at the time of surgery, there will be no cancer remaining. Those women tend to do better when they respond that well. Why else would we give chemotherapy up front? One, we can determine if the cancer is going to respond or not, as we expect it to. Because if not, there are studies now that show us we can give chemotherapy on the back end, and those women will do better. For HER2 positive cancers, we also tend to give chemotherapy up front along with those targeted HER2 drugs You may have heard of trastuzumab or pertuzumab. So chemotherapy can be offered in more advanced cases and in certain cases, triple negative and HER2 positive breast cancers, up front or after. But this is to decrease the risk of the cancer coming back to other parts of the body. I want to briefly revisit the disparity. Why is it that Black women have a 40% greater death rate than white women with respect to breast cancer? Why is that? That's important. I mean, if you think about it, we understand that there are socioeconomic, cultural, educational barriers. We understand all of those things. But the question remains, is that all? Is that all to the story? Couldn't there be more? What about the tumor biology? Could it be that Black women have different genetic makeup, different tumor biology, different molecular profile? This now takes it down to the gene level. We talked about targeted agents. So we can also talk about precision medicine, what I like to call precise medicine. You treat that individual according to their tumor, not just their triple negative status or their ER positive status, according to their specific tumor biology. But how do you do this? How do you know how to treat a Black woman according to her tumor biology without understanding her tumor biology? How do you gain that understanding? Something we call clinical trials. You know, this is a new era. Things are done differently now. And it is so important that as Black women, we get involved in clinical trials. So many drugs, just over the last few years, are being introduced. So many drugs have gained what we call accelerated approval because they're really showing improvements. They're showing extension of life. But we can't offer these drugs to certain populations if we don't understand the tumor biology. We can get so much better. It's so important that we are included. It's so important that we are studied. This data shows that Black women on a whole are, I like the term, under-researched. We can't be accounted for if we're not involved. So make sure to ask your medical oncologist, is there an option for clinical trial? Allow yourself to receive standard of care, which is totally appropriate, and then these newer drugs that are on the horizon. We need to know, we need to be involved. Precision medicine is an amazing new field where we are really, really honing down. We're starting to target breast cancers like never before. There are now new therapies that I am using that I didn't use 2 years ago. There are women who are now being treated who are leading normal lives. Understand that these new drugs are not just offering longevity, they're also offering quality. So not only do you get the quantity, the longer life, but you get quality of life. Because they're more precise, they're less likely to have those toxic side effects that we see with a number of our chemotherapy agents. So these women are going to work. They're spending time with their families. How important is that? This is so important for us. This is an exciting time in the development of these novel agents when it reflects breast cancer. And we can be a part. Regardless of what you have forgotten during this talk, do not forget that early detection is key. Do not mistake anything I've said. And do not misunderstand that the earlier that a breast cancer is diagnosed, the more likely you are to survive and live a normal life. The data repeatedly shows that. And for women who are actively being treated, we congratulate you. We support you. Be involved as much as you can in the clinical trials. And even though October is designated as Breast Cancer Awareness Month, I challenge you in 2021, make every month, all the other 11 months, just as important. Pledge to every month remind someone, your coworker, your neighbor, your friend, your sister, your aunt, to have their annual yearly mammogram. It saves lives. Thank you so much, Memphis Breast Cancer Consortium, for the concerted efforts that you have taken, especially in this Memphis community, to swing the pendulum. The process has begun and will continue, and we will do better. Thank you.